And so, all right, so this is not, let me see, change this out. All right, how does that look?
Looks great.
All right, so let me get started. Having issues with this. All right, here we go. All right, so as Dr. Barton said, I'll be talking about research designs and tips for data collection and preparation. I'm assuming that pretty much everybody here is a medical student, maybe a research associate or resident. So hopefully this won't be too much overlap of information that you already know. So we'll start off with looking at methods for choosing a research question and just a couple of tips for that, and then go on to research study designs, defining them, talking about a couple of the advantages and disadvantages of those. And I'll provide an example for each one as I go along. And then at the end, I'll provide tips for collecting and preparing data. All right, and so usually when we're talking about conducting research, you know the general steps, thinking about your research topic, you identify your research question and form a hypothesis, and then you select your study design, you collect your data, you analyze it, and you interpret and report your study results. And it seems like the lab has a long history of doing that successfully, as we just saw. So usually when you're doing those steps, you go through and perform a literature review, you make observations while you're in the clinic, as well as talking with other experts and your colleagues to help you narrow down a topic and figure out where there are some gaps in the literature or information that's needed. And this can help you with determining your study subjects as well. So you may know you want to look at obstetrics, for instance, as your research area, a broader research area, but you don't know within that where you want to focus your efforts. And so I'll talk about a couple of steps for identifying a research question and forming that hypothesis. But mainly, like I said, I'm going to focus on selecting studies. All right, so this is something that one of my biostats professors taught me a long time ago, and is about if you get stuck trying to figure out where do I go next with my research. And so this was something that was really helpful for me. And it's, I'll give an example of it, but it's really helping you to narrow down a topic or kicking off from a previous project where you would like to go next. And so like the general formula here would be, you could change one of three things. You can change your risk or your exposure, you can change the disease that you're going to assess, or you can change your population. And so for the first example here, we have someone conducted a study on cigarette smoking, and they wanted to look at asthma as the outcome in adults 18 and over. And so after, maybe there are several studies done on that, we wanted to shift gears and try to determine, what other areas that we can look at. And so one thing that you could do would be to change the exposure. So instead of looking at cigarette smoking, you may look at e-cigarette use and vaping, but use the same outcome. So asthma in adults 18 and over. Second option you have is to change the disease instead of changing the exposure. So you're still looking at cigarette smoking like the original study, but then you're changing your outcome to, for instance, COPD, chronic obstructive pulmonary disease. And you're still looking at the same population, so adults 18 and over. And then a third option is you can change the population you're looking at. So you continue to look at cigarette smoking and its effect on asthma, but you decide to look at teens. And then alternatively, you could shift gears completely and do a synthesis or a review of previous studies. And if you've already done a thorough literature review, then that may be a really good starting point for you to determine where those other future studies will go as well. And that'll help with your introduction and background. And so when designing your study, there are several considerations. Hopefully you can see here some of the different study designs, but if not, if you can't see it well from this table here, I'll I'll have another slide that's talking about each one of these. But we're going to just go over 4 or 5 of these briefly. And then the other ones, if we have time or you have questions about those, I can mention them, or you can email me and I'll be happy to talk to you about it at a later time. But things you need to consider when you're trying to determine what your study design should be is feasibility, number one. Do you have the tools you need? Is the population available and accessible? And is the data available to you to be able to conduct the study that you have in mind? Because a lot of times we'll have these grand ideas about the type of study that we want to do, and it will just not be allowable in for one reason or another. So we have to make sure that we have all of the tools we need available to us to conduct it in the format that we want to. A second consideration is cost. And so is there a cost for instance, data acquisition, or if you're going to conduct a survey, do you have funds for survey implementation? Does your department have funds to cover any expenses incurred, such as participant incentives or funds for data analysis or publication fees and things of that nature? So there are a lot of costs that you have to consider. The third thing is the length of time to complete the study. So as medical students or residents or individuals and programs that may have determined deadlines, you want to make sure that if your advisor is not going to carry on the study, that you're able to complete it in the allotted time that you have. So realistically thinking about time management, because the IRB alone can take a couple of months and a lot of unexpected things can pop up. So you want to make sure that you have a sufficient amount of time to conduct the actual study. And then the last thing is risk and benefits to study participants. So will people want to actually participate in your study, and do the benefits outweigh the risk for them? And then really importantly is how will you protect their information to make sure that the benefits do outweigh the risk? And so I just wanted to talk really briefly about some inclusion and exclusion criteria when you're thinking about your population. And this is important to consider for who can and can't be included in the study. And it also goes back to those IRB regulations that I mentioned. And so you want to make sure if you're looking at a population that's considered a vulnerable population, that, for instance, they're pregnant women or children are considered vulnerable populations. So you want to make sure that you have enough time to complete all the IRB requirements for a study that includes those populations, as well as clinical relevance. So you may have a study in mind that would be great and is very interesting, but is it actually of any clinical significance? Are people going to want to read your work, and is it going to have a significant impact on the medical community as well as patients? And then just having common sense about the type of things that you want to study. So an example would be you want to conduct a cohort study comparing developing prostate cancer between physically active adult males and males who are not physically active. Things you have to include: biological males. People you would need to exclude would be males who already have prostate cancer, because you can't assess the risk of developing it if the person already has it. So that's just, a very simplified example, but. And so now I'll get into the types of study designs, and we'll stay there for the remainder of the talk. So there are 2 general types of study designs. There are descriptive studies and there are analytic studies. And so under this descriptive studies, you're really answering questions like the 5 W's: who, what, when, where, why, and things of that nature. And so you're really looking at person, place, and time. And these studies can be qualitative or quantitative. And so, for qualitative, that would be interviews, focus groups, things of that nature. And then quantitative, what we generally think of as the surveys or having things out on a Likert scale or things like that. And an example of a descriptive study would be if someone asked the question, in Norfolk, Virginia, what percentage of first-time mothers attempted to breastfeed in 2016? So here for our population, we have first-time mothers. For the place, we know we're looking in Norfolk, Virginia, and then for the time, we're looking in 2016. And then for the analytic studies, these type of studies are where you're comparing groups. So in the descriptive studies, we're just describing people. We're not comparing groups, but in analytic studies, we're comparing groups, and they can either be an experimental study design or an observational study design. And so an example of a question that would be under the analytic study design would be, are women with a post-secondary education more likely to breastfeed than women without a post-secondary education? And so our comparison groups would be the women with and without the post-secondary education, and we'll be looking at breastfeeding. And so under the study designs, the ones we're going to primarily focus on today are the analytic ones, but I will briefly discuss the descriptive ones first, just because I feel like, especially in the past, the medical community, physicians have really contributed to descriptive studies, just because you're able to notice things in clinic that epidemiologists and biostatisticians may not have access to. So I'll talk about that first. And those are case reports or case series. And then I'll talk about the experimental and observation study designs. So for case reports or case series, case reports are simply detailed descriptions of one patient. And so an example, older example in the literature is that there's a case where there's a 40-year-old premenopausal woman, and she was on oral contraceptives, and her medical provider noticed that she had a pulmonary embolism and wanted to see, I guess, if that was in the literature, and didn't find that, so was able to create a case report. And that was in the early 1960s. And now, of course, we know now that oral contraceptive use can increase the likelihood of pulmonary embolisms. But that was an important example of a case report back in the 1960s that helped to establish that association by simply describing a case of a patient that they had. Case series is an extension of the case report. So that's a detailed description of 2 or more patients with the same disease or condition. And so an example of that in literature is where there were 12 patients with progressive facial hemiatrophy, and 5 of those patients had a coexisting linear sclerodoma on cul de sabre lesion. And so what the authors concluded from this case series was that there's a suggested close relationship between these 2 conditions. However, as you can notice, they did not include a comparison group. So this is why it would be under the descriptive category. All right, so there are some pros and cons to case reports and case series. And so we'll start out with all the advantages of it. So case report and case series really help to detect novelties and generate hypotheses, as well as research rare disorders, because, you know, the case report and case series that get published are new conditions. And so they help you to think, oh, this might be potentially related to certain exposures or certain outcomes, depending on the condition that the person has. It also promotes continuing clinical education. So making sure that providers are, you know, noting and paying attention to really unique cases that they see in the clinic, and then reporting on those so that we can determine if other people are seeing similar cases, and so that we can open up new lines of research and conduct those analytical studies that would follow from these descriptive reports. And these are no cost or low cost studies. So generally, you just have to get the permission of the individuals you include in the study, do an IRB, and then you may have to pay some publication fees, but overall the cost is very low compared to other study designs. And then there's also reduced time to publication. Some of the disadvantages are that there's a lack of generalizability, because you're looking at instances that are so rare or unique, and that you can't establish a cause-effect relationship because of the fact that you're assessing this person at this one time. And then there's publication bias. So it could be a limiting factor, as journals generally favor positive outcome findings. So approximately only 5% of case reports and about 10% of case series report treatment failures. So it's really geared toward positive outcome findings. So that's one area of concern. And then lastly, the retrospective nature, of course. So you can't determine, for instance, the risk of having that condition. All right, so I'm going to shift gears from the descriptive over to the analytic. And I'm going to start with experimental design. So I'm sure everyone knows randomized controlled trials, or RCTs. These are experimental studies where the researcher assigns treatment groups or such as an intervention for a certain medication, and then a control group, and then uses random allocation and observes outcomes. And so the important terms here are really that there's random allocation, and this refers to dividing the study participants into treatment groups to reduce bias and confounding. And this ensures that each participant has an equal chance of being selected for each treatment group. And so the way to do this generally is, I know an older way of doing it is you'll have a table of random numbers, and then as patients are entered into the study, they will be put into the random numbers, and that's how they'll be assessed. Also, there are random number generators on the computer, which is much more utilized today. But most statistical programs can create a random number generator so that that it can be determined, a person can be randomly allocated to a treatment or control group. An example of this would be looking at a population of individuals with type 2 diabetes mellitus, and there's a treatment group that receives 100 milligrams a day of aspirin, and then there's a control group who receives the placebo. And the researchers would evaluate the estimated glomerular filtration rate, or EGFR, and rapid decline in renal function for a 1-year period. And so these individuals were randomly allocated into those different treatment groups, and that's really what sets apart, and they follow them closely throughout the study. So some of the advantages for randomized controlled trials include that it's the strongest evidence regarding cause and effect relationship, because we know the person doesn't have the condition at the beginning of the study, and that we also know that we're giving a specific treatment to each of the study participants. So they don't get to selected. Usually there's some form of blinding so that the investigator, at least either the investigator or the participants or both, are not allowed to know who's in what group. And that really helps to reduce bias and confounding. And then RCTs are considered the gold standard because of all those reasons. As far as disadvantages, RCTs are very time consuming and can be expensive. There's also a likelihood for loss to follow-up, especially if there are adverse events that occur. And there can be non-compliance or early termination of a trial depending on how well or how poorly the treatment is going. And then there may be ethical considerations as well. For instance, if the treatment is really working well for the treatment group, then at what point does it become unethical to not offer it to the individuals who are in the control group? And then for the last disadvantage is that there's less generalizability. So usually the study subjects are closely monitored, and they may be treated differently than patients in a normal clinical setting. So in general, RCT's results only apply to the populations that resemble the study sample. All right, and so for as far as observational study designs, we have cohort studies, case control, and then cross-sectional studies. And so for cohort studies, it's like RCT, except we don't get to choose which treatment group the people are in. So it's an observational study where the researcher observes and does not intervene on a cohort who is initially disease-free. And when I say disease-free, I mean disease-free for the disease of interest, not necessarily disease-free for all diseases. And then these individuals are grouped by their exposure status, and they are followed for a period of time to see who develops the disease. And so a lot of times if we're not able to do a RCT, people can do things such as a cohort study. And so one example would be what is called the Framingham study that began in the 1940s. And so individuals residing in Framingham, Massachusetts without coronary heart disease were the study population. And some of the exposures that they assessed were smoking, obesity, and elevated cholesterol levels. And they looked at the risk of coronary heart disease in those who were non-exposed. So for one set of analyses, the exposed people would be smoked, but non-exposed individuals would be those who did not smoke. And then we would follow those individuals up to see if they developed heart disease over a certain period of time. So this Framingham study is actually still going on, and it's multi-generational at this point. And they've assessed a lot more exposures and even, I think, expanded some of the outcomes. So here are some of the advantages and disadvantages for cohort studies. You can research rare exposures because you're grouping them by their exposure status. And as you just saw for the Framingham study, you may be able to assess the multiple effects of an exposure, as well as measure incidence directly. So measure the risk directly, because we know that study participants don't have the disease of interest at the beginning of the study. And you can establish temporal relationships. So you know that the exposure came before the disease or the outcome. However, just like RCTs, it can be time consuming, very expensive, and it may, you may have lost the follow-up, but they're also, cohort studies are also inefficient for studying rare diseases. So if the disease is rare, so usually we think of less than 10% of the population or so, then it may take a long time to even have enough subjects who develop the disease to be able to do the analysis. So it's really not very efficient for rare diseases. An alternative are case control studies. So these are observational studies where the researcher identifies the cases, so the individuals with the disease of interest, and then corresponding controls, so individuals who do not have that disease of interest. And then they retrospectively examine their exposure history. And so an example of this would be if a researcher wanted to determine if physical activity was a protective factor against gastric cancer, what you could do is have look at hospital records for individuals who are recently diagnosed with gastric cancer, and then select matched controls from the community. And so there are several different kinds of controls that you can utilize for case control studies, but that's one type, so matched controls from the community. And they could be matched on things like age and biological sex, for instance. And then having the person go back and look and see if maybe 10 years ahead, prior to the study recruitment, how their physical activity levels were. And this would help determine if physical activity protects against gastric cancer. So as you can imagine, there's some advantages and disadvantages. Here, I'll change it up and I'll start with some of the disadvantages. Selection bias is a big one. So if we're including cases or controls and their inclusion depends on the exposure of interest in some way, or if the association is different for the study population versus the target population, then that could lead to selection bias, as well as information bias. So this can also be known as observation bias. So for instance, if a person who has the disease is asked to recall if they had some exposure, then they may recall more efficiently their exposure status than someone who doesn't have the disease, because they're trying to think of potential reasons or causes of their condition. An investigator may record or interpret information differently as well if they know a person is a case versus a control. So you really have to look out for the different forms of bias. Case control studies are also not efficient for rare exposures. So if you have a hard time going back and finding the exposure because it's rare, then that's not going to be really advantageous for case control studies. As well as you cannot directly calculate risk or incidence. And so this is because you're starting out with the individuals who have the disease. You already know who you're selecting to have the disease, who has the disease. So you can't really assess risk, because starting out at the beginning of the study, you already know who has the disease and you're picking your controls, matching them based off of that. So you can't assess risk. And then also the temporal relationship may be difficult to verify. So even though a person, you may go back and look at a person's history and find that they did or did not have an exposure, you're not really sure if they had developed the disease and just were not diagnosed at that time, or what. So the temporal relationship is a little more hard to verify. But the advantages are that you can look at rare diseases and diseases with long latent periods. So if it takes a long time for the person to develop the disease and to the point where it can be diagnosed, then case control studies would be good for assessing that. You can also examine multiple risk or protective factors simultaneously, as well as it takes less time to complete than cohort studies or RCTs, and it's more cost efficient as well. And then for the last of the observational study designs, we have cross-sectional studies, which I think a lot of medical students and residents do as well. And this is an observational study where the researcher collects exposure and disease information at the same time. So it's a snapshot of a condition at one point in time. And so an example of that may be if someone conducted a survey and they wanted to look at medical students to see if their social media use impacted sleep quality. And so they had the students complete a survey and ask them all the questions about social media and their sleep quality at the same time. And so they could assess that relationship. And so some advantages of cross-sectional studies is that they take much less, a lot shorter time to complete the study because you're just doing essentially a one and done. Sometimes people can do like repeated cross-sectional studies, but we won't get too into that right now. But essentially, you're just capturing all of the information at one point in time. And it's also less expensive to do it this way. And this obtains prevalence data, not incidence information. So you're not being able to assess the risk, but you are able to assess the health status or the prevalence of a outcome or a disease in the population at that point in time. And it can also reveal initial associations between variables and generate new or additional hypotheses for further study. Some of the disadvantages are that you can't establish the temporal relationship. So you don't know whether the exposure can happen before the disease or vice versa. And then, like I said, you cannot assess incidence or risk. And so here is the point for a little bit of participation. I'll give you 30 seconds or so to read over this and then determine which study design you think this is an example of. And either you can put it in the chat or you can say it out loud if you feel comfortable. All right, and so has everyone can I get a thumbs up if you had a chance to read it? Okay. All right, so anyone willing to take a guess at which study design it is? All right, so someone says case control, another person says case control, another person says case control. All right, so let's see here. Someone says definitely not RCT or cross-sectional. All right, so let's close this up. All right, actually, this is a cohort study, and I'll say why. I'll go through why it isn't each of the other ones and why it is a cohort study. So it's not a randomized controlled trial because the investigator did not randomly assign the women to hormonal abnormalities. And it's also not cross-sectional because participants are non-disease of the study initiation and exposure and disease information are not collected at all at one point in time. As far as the case control goes, it's not case control because it may be tricky just because of the first sentence, but here, if you notice, we're saying we're assessing by we're grouping by the exposure. So we're looking at women with hormonal abnormalities and women without hormonal abnormalities. And then we're looking at breast cancer as the outcome. we don't know if they have breast cancer or not. So that's why it's not the case control study, because we're not starting off by looking at women with breast cancer and women without breast cancer. If we were doing that, it would be a case study. However, it's a it's a cohort study, because we're grouping by the exposure, which is the hormonal abnormalities. And then we're following them over time and recording the outcome. So I hope that's a little clearer. And I know I went through a lot of study designs all at one time. Here are some of the ones that I went through. We didn't really talk about systematic reviews or meta-analyses because I didn't have time to go over that. But we looked at descriptive studies, so case reports and case series. And I had this little dashed line to cross-sectional studies, because cross-sectional studies are kind of like case report and case series, except that they have a comparison group. So for the analytic study designs we went over for the experimental one, we went over randomized controlled trials. However, there are also non-randomized controlled trials that we didn't get a chance to talk about. And then we also went over observational studies, so the cross-sectional, the cohort, and the case control. All right. And so for the tips for data collection and preparation, I have a few, and then I'll have a couple examples, and I'll be done. But first, once you decide you want to research a specific topic, it's advisable to contact an epidemiologist or a biostatistician. And because the earlier you get them involved in the process, the more efficient you can be, and the quicker you can determine what the best study design is for your project. And once you start down that route, make sure that you please always remove any identifying information. I can't tell you how many times I've received data with identifying information from researchers. And it's really important so that people won't have HIPAA violations or IRB violations. It's very serious. Patient protection and confidentiality are the utmost importance. But as far as the data collection and preparation, you want to make sure that you create what we call a data dictionary. And so this is just a basic Word or Excel document most of the time with the pertinent information on the data that you plan to collect. So all of the items that you want to have included in your study. And some of those things may include variable names, labels, the unit of measurement, the type of variable, the permissible values or range, the definitions for derived variables, and then other logic or consistency checks. And so I'll give examples for each of those. So for the variable name, you want to make it something simple. Usually most programs will accept 8-character variable names, no spaces, and then having letters, numbers, and potentially underscores if you want to include those. And so that's what's just the name is going to be in the data set, but the variable label is what you would call it in everyday language. So for instance, if our variable was named systolic, then our variable label will be systolic blood pressure. You also want to include the unit of measurement. So we're measuring that in millimeters of mercury, as well as the type of variable, whether it's continuous, discrete, categorical, and then permissible values or ranges can include, for this example, anywhere from 60 to 240. And I know that's a huge range, but I just gave a number for potential systolic blood pressure. And for instance, if you're going to have definitions for deriving variables, if you're going to include something like body mass index, that's composed of 2 other variables. So you want to make sure that when you're collecting your data, you remember to collect a height variable and a weight variable separately, and then you can calculate the BMI later, or your biostatistician can do that later as well. And then you want to make sure you have other logic or consistency checks in place. So you want to make sure that whoever's inputting the data doesn't mix up systolic and diastolic blood pressure, for example. Excuse me. And so here's an example of a data dictionary. As you can see, we have the name for each one of our variables. So we have group, age, sex, we have HT for height, WT for weight, etc. And then we have the labels that we want for each of those. So this is what we would see in a report or something of that nature here. We want to have the role. So this variable, the treatment, is the predictor. These other variables are covariates, so potential confounders or modifiers in the relationship between the exposure and the outcome. And then the outcome. So here is going to be binary. It's going to be looking at complications. For the type, we have whether it's binary, continuous, or discrete, or categorical. And then for units, F, applicable. So for age, we're looking at years. For height, we're looking at inches, and etc. And then for values, we want to say the possible range or what each of the values stand for. So for the treatment groups, we have 1 equals a placebo and 2 is the treatment. So here's a data spreadsheet that's really not helpful for analysis. And there, I could talk about this for 10 minutes straight, why there are issues with this spreadsheet, but I'll go through some of the main things. So as you see, like the first 3 rows here all have like descriptive information. We only want 1 row of descriptive information, and that should just have the variable names. We don't want multiple rows of text here that are not values for each of the variables. So we would only want here the top row, for instance, age, gender, height, weight, etc. And then we see here, we have drug A, and later on they have drug B down here. So the better thing to do would be to put drug type. And then we could say whether they're using A or B, and then have a separate column for their ID. We also don't know if these are the same 10 people receiving both drug A and drug B, or if these are 20 different individuals. So you want to make sure that each ID is unique to each person, and that is very clear. Here for age, we see that this person has some text included in their numeric variable. We don't want any text included in the numeric variable. If we're not sure about something, you can either put it as missing, so put a period, or if you want to be more specific about why that information is not a continuous value, then you can have codes such as 999 that would be outside of the range of a person for age. And that 999 could stand for, this person is missing information, or, this person did not respond to this question. Another error that people commonly make is not being consistent. So here we see we have male, that's capital M, and then lowercase rest of the word spelled out, whereas here we see a lowercase m for male, and same thing for female. And we want to be consistent about that throughout. And so those are some of the major ones. And then lastly, here is an example of a beautiful spreadsheet. And I have to say, give kudos to Dr. Martin, because her spreadsheet this is not her spreadsheet, but the one she gave me was one of the most beautiful spreadsheets I received for analysis. And I really appreciate it because it made the process go much quicker. So this is a wonderful example of what a good spreadsheet would look like. And if you ever need to know, just look at one of Dr. Martin's. So it's a great example. And then I have my references here. I did see that there's one question in the chat, so I'll stop sharing and then I'd be happy to answer that as well as any other ones. Sorry if I went a little over time. Okay, here. It says, how do you address the ethical issues as far as one receiving a placebo intervention and treatment? Okay, so what people usually do is if there's a standard treatment that's already being given to individuals, then they'll give the control group that standard treatment or the standard of care treatment, and then they'll give the treatment group that new experimental treatment, so that the first original group will only be receiving the standard of care, but they will not be receiving a placebo or ineffective medication. So that's what's usually done for that. All right, that's the only question that I see. Are there any other questions? All right. All right. It says, what is the rule for consent for case studies or case series? So it may depend on the institution, but what you always want to do is check with the IRB, and depending on what information you'll be using, There are certain protocols. For example, if there's a condition where you want to include photographs, you'll have to do certain things such as like obscure, like blink out someone's eyes or face or different things like that, so that the patient's confidentiality will be protected. But your IRB will help you determine what you need to do for case series or case reports. But you generally would have to get the permission of the individual to be included in the study, get their consent, especially because it's a rare condition. So it may be easier to identify that person. All right. I'll give it another second to see if any more questions come through, and then I'll hand it back over to Dr. Martin or DaShaunda. All right. All right. I don't see any more questions, but thank you so much for your time, and I hope this was helpful. I'd be happy if anyone was interested in sending out the slides. I'd be happy to do that as well. So.
Thank you so much, DaShaunda. That was very helpful, very practical knowledge, especially the spreadsheets at the end, because we've all seen examples on both sides. And so your value of knowledge is very appreciated. Yes, Bhushan will take your slides. I think those are very helpful, especially the examples that you gave at the end. And the study design, I know sometimes it can be a little like, oh, well, this seems like something I already know, but then you get into it when you're making your research question, right? And you're like, oh, actually, what study design am I doing? Or what study design is this paper? So when you really start getting into it, it's good to have good, like a well-formed foundation of knowledge, like what you went over. So when you are critically reading the literature for the medical students, or when you're designing a research study for the other lab trainees, you can think about the most appropriate design for your research question.
Yeah.
Awesome. Well, thank you so much, DaShaunda.
Yeah, thank you all for your attention.
That was excellent. Okay, well,